well, welcome everybody to the first class. My name is Mike Reed. I'm a pharmacist here. I work primarily inpatient, but I also work in the heme and PMT clinic. And we're going to be talking about cancer chemotherapy today, starting off with the old drugs, as Mike said. So we'll get through anthracyclines, taxanes, Vinca Alkaloids, Phytotoxins, which is Etoposide, and maybe Epothilones. There's 169 slides. We're obviously not going to get through all of those slides. The ones, headers in blue, we're definitely not going to talk about. That's reference material for you guys. We'll probably get through maybe 60 slides or so. They should be numbered, so you can follow along. I don't know if you printed them out or not. Feel free to ask questions either verbally or else if you want to do in the chat, because we definitely want your experience and examples to share with everybody. All right. So to get everybody thinking for Monday morning, I know I put this last year, but for people who haven't seen this or thought about this, and I've had like pharmacy residents who go into oncology and have never thought about this. So why is chemotherapy unique among medications that it is most often dosed based on body surface area? Is there anything special about it? We have lots of toxic drugs and therapeutic drugs, but for the most part, I really don't know any that we dose per meter squared. And we'll get to that at the end of the class or discussion. So just starting quickly at the beginning, this is the cell cycle. G1 is when organelles are synthesized. S is the DNA synthesis, and G2 is when you get mitotic spindles and things necessary for mitosis are created, and then M, of course, is mitosis. So the drugs we're talking about, Etoposide is G2, and the Vinca Alkaloids and Taxanes really work in the M phase. And if you look at the right, drugs such as the anthracyclines are non-cell cycle specific, so along with a lot of other drugs. So they work on preformed DNA, so they're going to work in any of the cycles or all of the cycles. They will preferentially work, are more effective in one cycle than another. So just to get back to the classic cytotoxic chemotherapy, this is kind of just a reminder of things to think about that obviously they function differently than targeted therapies. So the first one we'll just mention is Gompertson growth. This was I don't know what century, but an English actuary, and he plotted like these different types of curves. And this really means that it's kind of an S-shaped curve, a sigmoidal curve. Early on, a tumor has slow growth, then it experiences exponential growth, and then it has slowed growth, maybe because it's running out of different resources, and then it plateaus. And chemotherapy is going to be effective or less effective at different stages. The Goldie-Coleman hypothesis says resistance is independent of the chemotherapeutic agent and dependent on the number of cell divisions that occur after treatment that begins. So this kind of makes sense that the more cell divisions you have, the more chances that your tumor is going to develop resistance. So the larger tumor size and also the longer delay in initiating therapy can contribute to more resistant cells. The tumor log kill, fractional kill hypothesis says that a fixed percentage of tumor cells are killed with each cycle. And if you ever looked at a curve, for example, you could have 90% are killed with cycle 1, and then of the remaining cells, the next cycle, 90% are killed there. And then the Norton-Simon hypothesis says the rate of cancer cell death due to treatment is directly proportional to tumor growth rate at the time of treatment, which basically translates into, for the most part, faster growing tumors are going to have higher death rates and maybe be more effective. You know, an example of that would be Burkitt's lymphoma. So these are the drugs that we're going to talk about, are the classes of drugs. These are very old. They're older than pretty much every person in this room. And so the 60s, Vinca Alkaloids, 70s, anthracyclines. So none of these are targeted medications. They were all discovered, for the most part, either serendipitously or generally through screening programs where people were actually looking at different substances and testing them by the tens of thousands to see if they had any type of anti-tumor activity. And as a result, most of these, if not all of these, eventually came from either plants or animals or bacteria. So the anthracyclines are natural products isolated from Streptomyces and synthetically developed, which would be epirubicin and idarubicin. They're deeply colored agents. They're originally synthesized as stable dyes, which is why they're bright red or can be bright red. They're one of the most common used anti-cancer agents, and the spectrum of activity is pretty broad, and it's similar to alkylating agents and taxanes. So anthracyclines really can work on lymphomas, they work on leukemias, they also can be used to treat solid tumors. So these are just a list of them here, and I just wanted to point out that there's 3 are available in liposomal formations, which are not equivalent to the ones that the standard non-liposomal ones. And I will point out at the very bottom that mitoxantrone, which we include here, is technically not structurally an anthracycline, but it's generally lumped in this class because it's used for similar types of indications, and it actually has similar mechanisms of action. So these are the anthracycline structures here, and we're obviously not going to dwell on a lot of structures, but I did just want to point out that even though daunorubicin and doxorubicin, for example, are very similar, just a different hydroxyl group, and I don't remember what position that is, but they do have different spectrums of activity. If you look at daunorubicin, it's more active against leukemias, whereas doxorubicin is more active against solid type tumors. And if we look at the bottom here, this has a very similar structure, mitoxantrone, but technically it's a little different, so it doesn't fit into that same class. So I'll jump right into the multiple mechanisms of action. So the main one is the induced formation of covalent topoisomerase II DNA complexes. We'll have some schematics to look at in the next slides. So this inhibition prevents this religation of DNA, causing DNA strand breaks, and basically leads to apoptosis. And topo-2 inhibitors are one of the most potent inducers of apoptosis. There's intercalation between base pairs, which also inhibits nucleotide replication. And finally, there's enzymatic reduction, produces these free radicals that add to the cytotoxicity, but these also add to the cardiotoxicity of the drugs. And then just to note at the bottom that mitoxantrone does produce fewer oxygen-free radicals, which is probably the reason that it's less cardiotoxic. This is just a schematic for people who like pictures. It's topoisomerase II. I always remember the 2. We have double-stranded breaks. And they're not opposite each other, they're 4 base pairs apart, and it always really hits the same area of the DNA. And then they covalently bind to this DNA and prevent all these enzymes that are necessary for DNA replication to attach here. So that's the main mechanism of action for this. There's also intercalation, and these are these heterochromic rings, and they actually, if this is the DNA here, the red strands here are where they're inserted, if you remember what the rings look like. What it does is it causes this torsional strain on the sugar ribose backbone of the DNA, and it makes it more difficult for the enzymes or transcription factors to bind to this. All right, so how does resistance occur? Well, you can get decreased drug accumulation due to transport, and there's really 2, a multi-drug resistant gene product and a multi-resistant protein. You can have down, and I'll show the next slide. We have downregulation or mutations of topoisomerase II, so you can change these, this topoisomerase II, the tumor cells can change this enzyme so it's less affected by the binding by the anthracyclines. Increased neutralization. So basically, you cause fewer oxygen-free radicals. You can get overexpression of anti-apoptotic molecules. And again, mitoxantrone's a little different since it's not actively treated by the multi-resistant P1 pump. And this occurs primarily through alterations of topoisomerase II. This is just a picture, obviously, I find Google, which is really good to look at things. This is, as a pharmacist, they use the lipid bilayer. The cell is actually made of pills here. It's clearly not real. But this is the MDR pump here. And how it works is you get exposed to a medication like, for example, Etoposide, and the tumor cell starts producing these pumps in their membrane, and then they pump over totally structurally unrelated drugs. And that's hence the name of multi-drug resistant. So they're very, I don't know, I'd say intelligent, but they function in a very clever way that you can produce this and pump out things like you get anthracyclines that could confer resistance to taxanes. And these are the indications. We're not going to go through all these. I did just want to point out that, like I said, you have leukemias, you have lymphomas, you have Hodgkin's disease, and then you have lots of different types of solid tumors for doxorubicin. The way we're going to go through this is we'll pick a prototypical drug for each class and kind of go through this. And if there's important differences between the other drugs, then we can talk about those. So quick case, we'll do our first case. HP is a 35-year-old male with stage 4 Hodgkin's. He's receiving ABVD, which I have listed here. He comes into your clinic to receive his 5th cycle of ABVD and complains of tachycardia, shortness of breath, and non-productive cough. Physical exam reveals neck vein distension, pulmonary rales, and ankle edema. And he's just on amlodipine for hypertension. So we'll come back to him. So the toxicities we have, probably the first thing that jumps to mind is cardiac toxicity, and it's really divided into 3 different areas: acute or subacute chronic cardiac toxicity, which is results in cardiomyopathy, and this is really probably clinically the most relevant. And then you also get this late onset cardiotoxicity, which has dysfunctions like arrhythmias, and this can manifest years to decades. Quickly go through these. So the acute toxicity can happen like immediately after you're infusing the drug or while you're infusing it actually. And you get these electrophysiological or physiological abnormalities. The primary one is sinus tachycardia. This is the most common rhythm disturbance. And these are seldom serious. If you do look at the literature, there was early cases of deaths due to pericarditis, myocarditis syndrome have been reported. This isn't really predictable if anyone's going to get this acute toxicity, and people aren't monitored for this. We don't put them on telemetry for this. And just to simplify it, the mechanism of cardiotoxicity is really divided into 2. Death through type 1 is death through necrosis. Obviously, that's not reversible. And type 2, you could say that cardiomyocytes are actually stunned, so they could potentially recover from that. The chronic toxicity usually presents within a year, kind of by definition. The exact mechanism is unknown. I think we do know it. It's multifactorial, and it's really related to, it used to be thought to free radical damage, but now the evidence is really pointing to topoisomerase 2 beta damage to the myocardium. And we'll talk a little bit about that later. It is related to peak concentration, so that means quicker infusions, you have a higher risk of developing cardiomyopathies. And then they have the incidence listed down here, but I'm going to just show you this graph. This is doxorubicin, almost 4,000 patients, 88 cases of congestive heart failure. And if you look here, this is really where the concern, you get this rapid increase somewhere around 400, depending on where you look, they may say 450 milligrams. And this is kind of what we use for screening and decision support to make people aware of when you're more at risk. Keep in mind that people can tolerate, they can develop these symptoms, 250, 300 in some people, and other people can tolerate, 900 milligrams per meter squared. So it is very individualized, and obviously this is just a composite graph of, 4,000 patients. So there's a conversion factor for the toxicities. There's multiple ones that are available. This one just is seminars in oncology. It kind of gives you a good overview. Doxorubicin, if that equals 1, daunorubicin and epirubicin are half as toxic, meaning they can tolerate to get to this incidence twice as much milligrams per meter squared. And idarubicin would be per milligram twice as toxic, so you can tolerate mitoxantrone. So you can tolerate half of that, what you would expect to see the congestive heart failure develop. I don't know if anyone has looked at this. I just threw this in because there is functionality in HealthLink that keeps track of this. And all you have to do is type in lifetime dosing, and it pulls up this image. And for this patient, doxorubicin, it shows that we've administered so far 440 milligrams per meter squared. Gives me this percentage of an arbitrary maximum dose that's set in the system. These are what's set in the system to trigger alerts. So if the nurse is giving a med to the patient that's going to push them over that limit, they will get a warning that does that. So it's kind of nice. It has the different agents here. Also have bleomycin. Unfortunately, it doesn't convert to a total anthracycline dose. You have to do that manually. And you also have the option here where people can if you get treated outside of UW Health at your local clinic, you can actually go in and put the doses that patient received here, then use those to total it. So risk factors include high rates of administration, leading to high concentration, previous cardiac irradiation, elderly people, younger people less than 4, female sex, pre-existing heart disease, hypertension, and concomitant treatment with other meds that cause cardiac effects, and I have those listed here. There's likely also genetic predisposition, but nobody's figured out a good way to test for that. And again, we mentioned there's a wide variety of individual sensitivity to this. So prevention and monitoring of cardiac dysfunction, we won't go through all of these, just to say that you can categorize them in the risk depending on their overall risk, depending on what cardiac risk factors they have and what doses they have. And this is an ASCO guideline. And one of the straightforward, simple things to do is screen for actively managed modifiable cardiac risk factors, smoking, hypertension, diabetes. They also have cardio-oncologists that, can be involved. If you have people at risk, it probably makes sense to get them involved earlier in therapy. And these are just some primary and secondary preventive strategies that you can use. We'll talk about this, dexrazoxone, which is used to prevent toxicity, liposomal formulations, longer infusions, which isn't really practical for a lot of patients, and also certain things like ACE inhibitors, ARBs, or beta blockers. I don't know why that's not working. Okay, so this is our same patient. So what risk factors?
There's the arrows on the bottom there if you want to use that.
Yeah, oh, this one. Okay. So anyway, the patient is expressing symptoms of congestive heart failure. I don't have the calculation out here, but he only had 200 milligrams per meter squared, so it'd be highly unlikely that he would develop it due to the doxorubicin dose. But he did have a concurrent radiation therapy, and he did have hypertension. So this is probably an atypical presentation of a patient who's developing an early CHF. Right. This is just, there's different guidelines that you can have for adjusting it. You obviously want a baseline for everybody for their ejection fraction. If they're low risk, 30 to 50%, you want ejection fraction prior to each dose. If they fall into this greater than 50%, then you probably somewhere around 250, 300 milligrams, then you really want to be checking those again. Some people are much more conservative and we'll check them with each cycle. So prevention is key, limit cumulative lifetime doses if possible. Longer infusions are associated with decreased toxicity. Cardioprotective agents, we'll talk about this. We'll talk about these in a little bit. And treatment really, for the most part, necessitates lifelong learning, especially if you're younger when you receive these. What doesn't work? Lots of things have been tried. N-acetylcysteine, phentolamine, coenzyme Q10, different vitamins. Dexrazoxone is effective, but it's placed in therapy. I've seen it used maybe half a dozen times for this particular indication. I don't know if anybody else has seen it used more. It seems like peds may be more of a common user of this, which makes sense because they have a whole lifetime to develop these side effects. So it was believed to exhibit cardioprotective effect by chelating iron because it is an iron chelator, but then they found out like other iron chelators didn't work. So people were thinking, well, what's going on here? So really what it does is it prevents anthracycline binding to topoisomerase 2 beta, which is found in cardiomyocytes and a lot of quiescent cells. And when dexrazoxone binds to this, it prevents the anthracycline from binding to this and causing a toxicity. It's approved for metastatic breast cancer, not advanced breast cancer. ASCO guidelines for other malignancies are similar. It should work given its mechanism for, I have seen it used, for example, for idarubicin, even though there's not a lot of published data with other anthracyclines. And this is just a schematic for people who like pictures of how it binds to the topoisomerase 2 beta and prevents the anthracycline from binding. So why is it not used as much? So I was thinking about that. So it does have myelosuppression is potentiated. It's a small but significant measurable amount. And there's concerns with interference with the anti-tumor efficacy, lower response rates, faster tumor progression. And this was seen in a trial with early breast cancer, which is really the reason that doesn't have an FDA indication for that particular use. And it's also not known whether it's going to work for late onset cardiac effects. So moving on to some other toxicities, bone marrow suppression is primarily neutropenia, nadir 10 to 14 days, recovery 3 to 4 weeks. It is a vesicant, so obviously we've grown, and we'll talk a little bit about that because we do have a treatment for that. Nausea and vomiting, it's a level 3 to 4 medic potential. Mucositis and diarrhea. So anytime you have GI toxicity, it's for the most part going to be increased with prolonged infusions than with boluses. And alopecia is going to be universal. So extravasation, there's really good guidelines. You can look at them. It's just the common, stop injection immediately, aspirate, apply ice. You apply ice to most meds except for the Vinca Alkaloids, and we'll talk about those. And you can use hydrocortisone. But really what you want to do is, or may want to do, is you got dexrazoxone, Zenacard, Cardioxin, I don't know if I pronounced that right, but this is the drug that is FDA indicated for cardioprotection. And if you look here, Totec is the same drug, identical, and this is the one that's indicated for extravasation. And the company that made the Totec actually patented this process of using drugs to treat extravasation, and they sent out all this information that we're going to threaten you or sue you if you use this particular product instead of this one, which has the FDA indication and the patent, which is really kind of crazy, because when you look at them, they're the exact same drug. All right, so just quickly, this was a 53-year-old female with bilateral breast cancer. She got treated with THC. She later, against with progressive fatigue, a single episode, she has anemia with peripheral blood. This is a real patient. She had recent bone marrow, and she had therapy-induced AML. So she was getting treated with the standard 7+3 regimen. And this is actually copied right from the nurse's chart. And of course, it happens Friday at 8:15 p.m. So that's when you can expect to get your calls. So they were getting idarubicin, looking at the patient's chest, redness noted along the tunnel side of the catheter, and downward blood. They did have a blood return, attempted to lift the Band-Aid, pain. Patient was unsure if the redness had been at the site. So the concern was, did she have some extravasation with this, and what should we potentially do? So they stopped it and called the heme fellow with future orders. And the option would be, it's like, would you give dexrazoxone or would you not? You guys have any thoughts?
I think you can give it to be safe. You're still unsure of what the cause is.
Yeah, and I think the hard part of this is that they're trying to describe it over the phone to you, and you can't look at it. And hopefully that people are much, knock on wood, less familiar with extravasation because it happens less, than we're used to, because, all the central lines and stuff we do. In this particular case, they decided not to do it. And I'm not exactly sure why, but basically, if you ever need, for future reference, you can get a dye study done on a Saturday. And they found the catheter remained safe, at least this Saturday, they did, safe for the clinical service. And I think you might have an example of extravasation. One thing to think about with peripheral lines is there are specific antidotes, but also consider, getting plastics involved early to looking at that. All right. So this is just the dosing here. It's just to point out, it's just 3 days. You take the ice off 50 minutes before, and you infuse it in the opposite extremity. And it does have a renal function. All right. So other adverse effects: facial flushing, histamine release, doxorubicin flare, hyperpigmentation of nail beds, urine discoloration, red with doxorubicin and daunorubicin. Secondary malignancies, AML with cyclophosphamide. They used to be separated out between alkylating agents and topoisomerase II agents. For example, the topoisomerase II often had therapy-induced AML in a shorter period of time, 2 years, and no antecedent MDS, versus the alkylating agents, which was 5. But since a lot of people got the same classes of drugs, like the AC regimen for breast cancer. The fact is they're all high risk and patients are pretty much treated the same, but they're now all included in a general term of therapy-induced ML. And you can also get radiation recall, where you get irradiation and you get the anthracycline and it exacerbates the radiation damage, especially like concerning is if you get it in your GI tract. All right. So pharmacokinetics, we won't do a lot, but you should remember extensive liver metabolism and biliary excretion. And the different anthracyclines have different dose adjustments. So they basically give you dose reductions here. And this is just a reference for everybody. If anyone is interested and wants anti-cancer dose adjustments with renal and hepatic dysfunction, this is, I think, a really good reference. And the ones in blue, we're not going to go over. Those are just for your references. So just a quick HIV positive male presenting rapidly growing retroperitoneal mass, extrahepatic biliary obstruction, evidence of tumor lysis with urea neuropathy, plan to receive a cycle of R-hypercVAD, which the meds are listed here, for an unclassified B-cell lineage lymphoma and overlap features with Burkitt's and diffuse large B-cell. His billy was 6.8, uric acid 10, which is down from an outside institution. This is, again, another real patient. And creatinine improved from the mid-2s to 1.7. So this is the hyper-CVAD regimen that we want. Given his decreased liver function, does anybody know, would we go ahead and give this? Does anybody have any thoughts? Would we make any changes or alterations?
Probably have to dose reduce the doxorubicin or like give him some steroids to hopefully relieve the obstruction first and get his billy down.
Yeah, that's very much what was done is the dexamethasone was given, and actually the cyclophosphamide was also given, and they held the doxorubicin and vincristine, assuming that you would your liver function would improve and you'd be able to do that. So hold on doxorubicin or vincristine to the biliary obstruction. We consider if it responds rapidly. Raspberry case got 6 milligrams, probably get 3 milligrams now. Won't worry about the uric acid, but day 1, if we look at day 3, like transaminases are down, T-billy's down. So he was going in the right direction, and he did end up getting vincristine and doxorubicin. So I just want to quickly mention the liposomal doxorubicin is what's different here is it's a liposomal formulation. It has different indications, Kaposi sarcoma, ovarian sarcoma, and it's a short infusion. You don't give it IV push. It's not a vesicant, and it's, for the most part, not interchangeable. You can't just go one-to-one and change to the other product. It has different distribution, leading to different side effects. So the toxicities that you can have here, palmar-plantar, I have trouble pronouncing as erythrodysesthesias, so dose adjustments, your hand-foot syndrome, dose adjustments may be necessary, and stomatitis can be a dose-limiting toxicity. And I don't usually work in the gynecology clinic with gyne patients. The few times I've been there, I've seen people, I'm looking in the same thing in HealthLink, that they've got over 1,000 plus milligrams per meter squared of liposomal doxorubicin and are still being treated, which would be really rare to do that in a non-liposomal formulation. And I just put this in there because it's a black box warning, which makes sense. Okay. So this one, just Vyxeos, is really interesting. The drugs we've been used for the 70s for AML induction are cytarabine and anthracycline, in this case, daunorubicin. So they made this combination product that has a fixed molar ratio of 1:5. And what happens is it's given 99% of it remains in this liposomal formulation while it's in the plasma. It gets taken up by the bone marrow, and then it deposits, basically it taken up by the bone marrow and then the leukemic cells in there. And once it's in there, it breaks down and it releases the cytarabine and daunorubicin at this molar ratio that was designed. And this is the optimal killing that you get with this. So I think it's very interesting and clever the way they did that, because it's really hard to get the right concentration if one is like an IV push and the anthracycline and the cytarabine is a continuous infusion to do that. I think people thought this would be really effective. It's indicated for the high risk, so therapy-induced AML and AML with myelodysplastic changes. I think that because it does quote concentrate in the bone marrow, that people have more toxicities than they expected, and it's not used as often as I think people initially thought it would because of those toxicities. All right. So another case, this is a TAHBSO patient, ovarian patient, had a TAHBSO, got Taxol carbo, and patient experienced flushing, red face, heart racing, spots tightness. So they stopped it. This is for the paclitaxel infusion. And then they restarted, and the patient got a rash to the abdomen, arms, and thighs. And so they didn't give the cytarabine, did not give cytarabine at the time. There's no carboplatin. So then they had doxorubicin, and the patient also had an allergic reaction to this. She was ramped up halfway through her carbo infusion. She noticed a rash in her trunk and chest. So this patient had reactions to doxil, carboplatin, and paclitaxel. And she comes in the next time to get desensitized in a clinic. Again, this is a real patient. And she had the doxorubicin and carboplatin, so she was being desensitized to both. And the patient herself actually, I don't know how she saw the orders, but she goes, that's not right. I need to be desensitized. You know, I've reacted to all of these. So the patient actually had this. They printed him out. The allergist who put that note in the chart had the desensitization schedule in there. And it's like 12 steps. So, and 3 different products. So she ended up, 3 different solutions. So she ended up having to go home, and she was admitted to get her tolerance as an inpatient. But I find it like very interesting that the patient was like super alert. I suppose if you react to 3 drugs, and they tell you, we're going to go through this process. So the original orders didn't work. She couldn't get it done in clinic because it required, 12 hours or something to do that. And then basically there's 3 orders. And there's also like order sets for carboplatin desensitization if you need that. So we'll skip these. Mitoxantrone, well, just moving on, I just want to say is that dose-limiting toxicity is leukopenia, and as opposed to the other ones, doxorubicin was known as Red Death when it came out because of the toxicities that people experienced with it. This one's obviously blue, not known as Blue Death. All right, so we'll skip this one. So we'll move on to phytotoxins. Etoposide is the drug we're going to talk about. Extracts from the mayapple, mandrake plants. So this has been used for hundreds, if not thousands of years. Native Americans and natives of the Himalayas have used this. So it's a 2nd generation semi-synthetic drug. It's non-intercalating, so it's a pure topoisomerase 2 inhibitor, so that's different than the anthracycline. The use is approved here. You see it refractory testicular cancer and small cell lung cancer are probably the biggest ones. It does have some efficacy and is in some AML regimens, and I don't know if and some BMT conditioning regimens. What is interesting about this is it of the cytotoxic chemotherapy is it does have oral absorption, so 50%, which basically means, you can get your first dose IV in clinic, and then the next day you can get this home. So if you're 100 milligrams per meter squared IV, then you'll just get 100 milligrams per meter squared orally twice a day to go home. Some of the side effects are hypotension. Usually this is at higher doses if the drug's given too rapidly. Most of the order sets that we have here actually have parameters in there and saline boluses. It is available as capsules. And what I wanted to say is myelosuppression is dose limiting with conventional therapy, reversible, non-cumulative. Seems relatively quickly, it can. And mucositis, stomatitis are dose limiting with high dose therapy. 50% incidence of high dose therapy. We did have a patient who developed mucositis. I believe it was a lung cancer patient, and they were getting oral, and people couldn't figure out exactly why. And the thought was maybe that it was acting more as a continuous infusion with the absorption of the etoposide. And they actually did switch the patient to IV. Alopecia, people complain about the metallic taste during infusion, and again, secondary malignancies that you can get. headache, fever, bronchospasm. So there's alcohol is a diluent in here, which can cause problems, and disulfiram reactions if patients have one of those drugs. And dosing, the renal dosing they have here, I just want to mention the hepatic insufficiency is a little bit weaker, and the rationale for the hepatic is that if you have high bilirubin, it binds to albumin and it can displace the etoposide. Etoposide is highly bound to albumin, so at least that's the thought, is your billy is going to push the etoposide out and you're going to get more toxicity because you have more free drug. All right, so we'll move on to the Taxane. So paclitaxel is the original one, approved in 1992. We were actually a clinical site here studying it. There was controversy at the time. It was harvested or identified and isolated from the bark of the Pacific yew trees. So the trees, they had to cut these trees down, and there were people that were saying, you know, oh, these are hundreds of years old and shouldn't be doing that. So there's a semi-synthetic form of paclitaxel now, and it's made from renewable sources. But if you look at these, we're not going to go into any detail, but it's just a complicated molecule to synthesize, is why it took, you know, decades for the chemists to really figure out a process to be able to do that. So they promote the assembly of microtubules from tubulin dimers and stabilize it, which is different than the Vinca alkaloids. And I'll show you a picture on the next one, or a schematic. So the stability results in inhibition of this microtubule network required for interphase, and it slows or blocks mitosis for these cells. This is just a picture here. A normal microtubule has these little tubule monomers that they are added on one end and disassociate on the other. So they have these pool floating around. So the taxanes, not only do they bind to this and make these odd structures, but they also increase the number of these monomers, and you get this non-functional structure that you have. Multi-drug resistance, again, you have the multi-drug resistant pump, and also you have structural alterations of alpha and beta tubulins. So Taxol and docetaxel bind to slightly different sites, and then these cancer cells can change these tubulins and then make it less efficient for the taxane to bind to it. And you've got also upregulation metabolism of the enzymes. Skip these. The dose here has changed. It has been infused, so from an hour all the way when it first came out was 96 hours. And probably before you guys can remember is we had Taxol Tuesday here. So it was on S66. It was for the ovarian cancer patients, and patients would come in, and back then they received a 24-hour infusion of Taxol and then cisplatin after that. So really it was a 2-day process. So obviously logistically the 1 and 3 hour infusions are much more convenient logistically. So paclitaxel, we won't dwell on kinetics, but it does have a disproportionate increase if you ever look at the curve of this. So meaning when you have these higher doses, you increase it, you may have an unpredictable amount of drug. And this may be saturation of hepatic metabolism, or it may have something to do with the diluent. And we'll talk about that in a minute. Don't have to go through all these. So hypersensitivity reactions. So paclitaxel, when it was discovered, it was not soluble in most things that they could find. So they figured out a diluent called Cremophor-EL, which is polyethylene castor oil. And I don't know if any of you guys watched the Vacation series. That it reminds me of Griswold. Like, he's a food additive designer, and I'm thinking somebody else just sit around and develop diluents that aren't harmful for people. Anyway, so you have mild, moderate symptoms, and this is really how you're going to treat it. You're going to stop the infusion, and we have standard orders. So it's going to be an antihistamine, a steroid. You could use methylpred, you could use dexamethasone, you could use prednisone, an H2 antagonist. So we use famotidine and albuterol if they need that. So severe symptoms, you're going to stop the infusion, give a steroid, antihistamine, epinephrine, and bronchodilators if needed. If that's the case, you don't re-challenge with paclitaxel. Somewhere around 30 to 40% of people are going to react if you don't pre-medicate them. You can react to the taxane itself, but generally it's the diluent for paclitaxel. And then they developed a protocol, like a Cleveland Clinic, I believe, radio contrast protocol, and it's somewhere down to, you know, a couple percent that people react to it. These are the standard meds. This is from the prescribing information. Even at the time when the med was approved or soon after that, there was evidence out there, studies that compared that you could give 120 milligram dose of dexamethasone or even and you wouldn't really get any difference in the amount of severe reactions. And you could even go down to 10, and then maybe you had a small 1 or 2% increase. So I'm not sure like why this particular dose is needed versus a smaller dose. Because if a patient comes in and they forgot to take their dexamethasone, they would get 20 milligrams IV, and then they would continue to treat it. So I think the direction it's going is you probably reduce the dose, and in future cycles, oftentimes it's reduced. Neutropenia is dose-limiting toxicity. You can get severe neutropenia. It's non-cumulative. People do recover. Alopecia, you're going to see all these patients. Cardiac abnormalities. Hypotension is probably the biggest concern, so I would just make note of that if a patient's on a beta blocker when they come in. And peripheral neuropathy, of course, they list a huge range in the literature, increases patients with subsequent doses. It's numbness and paresthesia in a Stocking distribution. So it's the long nerves are more affected. The nerve body's generally spared, so people do recover from this. People usually subsides the results over weeks to months. And it's similar to the Vinca alkaloids, but more, but less toxic. So again, neuropathies, they can occur after a large single dose. I don't think people really use doses greater than 250 milligrams now, but generally occurs after multiple courses of this dose here. It's more pronounced with short infusions and weekly schedules, and certain drugs, cisplatin, can contribute to it. And of course, if you get Vinca alkaloids, it's going to be potentiated with that. So I just wanted to mention, you get nail disorders, pigmentation and discoloration of nail beds. Mucositis, I don't think anybody gets 24-hour infusions anymore. And alopecia is going to be universal in these patients. All right. So the other thing people worry about or are concerned about and affects their quality of life is myalgias and arthralgias. So you can get these flu symptoms 24 to 72 hours after. Usually self-limiting at the lower doses, higher doses, you get higher incidence. So it's somewhat related to peak. And it's weakly associated with cumulative dose. And as far as I'm aware, there's not any good recipe that you can give patients that are going to prevent this. The drugs, non-steroidals or opioids, prednisone, have all been tried. And it really isn't dependent on the infusion time. All right. And I just put this out here just because I wanted to have the black box warnings for docetaxel. If bilirubin is greater than upper limit of normal, which isn't that high, or if AST and ALT is 1.5 times with alk phos 2.5 times, then you really should avoid this because you do have increased mortality. So that's the black box warning with docetaxel. Also, severe hypersensitivity reactions, and they get a little different pre-meds. And part of the reason they get pre-meds is that they're less sensitive, they're less likely to react than paclitaxel because they have a different diluent, polysorbate 80. But part of the reason they get the steroids is because you have fluid retention for docetaxel that you don't have for Taxol. It's poorly tolerated peripheral generalized edema, cardiac tamponade, abdominal distension. It's increases at cumulative doses, which I have listed here, and that's one of the reasons you pre-med with dexamethasone day before, the day of, and the day after. The schedule's listed down, and it results slowly after discontinuation, and slowly means that it can be a median of 16 weeks, so 4 months before this resolved. All right, so neurological effects, similar to paclitaxel, but less intense. Asthenia, GI toxicity is mild to moderate. Hematological toxicities, you may have a deeper, lower neutrophil count, heme toxicities, but a relatively quick recovery compared to paclitaxel. And nail discolorations, hyperpigmentation. You can also get these skin erythema, desquamation. Don't know how often that happens. I don't know if anybody has any experience with that. Okay, again, renal insufficiency, probably not needed, but definitely for hepatic insufficiency, you want to make sure that if patients meet this criteria, that they don't receive the drug. I won't go through all the drug interactions. It's just an FYI. We'll skip this one for now. Okay. So paclitaxel protein bound Taxane. Do you know what time it is?
About 10 minutes.
10 minutes, okay. So protein bound particles, I'm just going to go to the summary of this. No pre-meds are necessary to prevent these reactions. Not necessary to use tubing, but in summary, this formulation has some notable advantages over conventional paclitaxel formulations. It can have lower toxicity, specifically severe neutropenia, shorter infusion times. I don't know if that's true anymore with the 1 hour Taxol. And one study did show superior efficacy to the conventional product. I don't see a lot of this. I know Ian Robbins had liked to use that. Part of it was, I think, initially that the cost was significantly higher. All right, so moving on to the Vinca alkaloids. These are naturally occurring semi-synthetic compounds found in the periwinkle plant. So they kind of changed the name, Vinca rosis, which is where the name of the drugs came from, the Chrysanthus rosis. Vincristine is more common in pediatric oncology and better tolerated in that population. Vinblastine common in germ cell malignancies and lymphomas. And it's just a picture of periwinkle, which is found in Madagascar, and another natural product. They're obviously structurally similar because they're all Vinca alkaloids. They do have similar neurological effects, but at different intensities, and we'll do that. So cell cycle specific, binds to sites on beta tubulin, different than the taxanes, so the Vinca domain, which makes sense. Again, they induce conformational changes, increasing its affinity for itself. So instead of stabilizing these tubules like the taxanes do, they make these, there'll be a picture in the next one. They decrease this pool of free tubulin dimers available for microtubule assembly, and it results in a shift of equilibrium toward disassembly. So the cell division is arrested in metaphase. They can't align, and basically it results in apoptosis. And this one is, so we have the same microtubule, and they have these free tubulin dimers, which are floating around that were moved from one end, added to the other. And the Vinca alkaloid, which is this little symbol here, actually binds to them and causes them to crystallize. And there's not this pool here available. So then you get equilibrium is displaced toward deep polymerization. So you really can't assemble these, that you need these for mitosis. Again, resistance, multi-drug resistant pump. And again, the beta tubulins, structural and functional alterations of these tubulins, so the drug can't bind to it. And they do share cross resistance with each other. The taxanes also have some cross resistance with each other. So I have to mention this. So it's fatal if given intrathecally. And people, you may think that it doesn't happen. We actually had a patient here at UW. It was multiple years ago. And usually the mix-up happened, if you look at the literature, is on when people are getting intrathecal meds the same day that they're getting an injection. An intrathecal, it's a 3 ml syringe that has, 2.4 mils of drug in it or whatever. And then it's the same thing. You'd have like 2 mils of intrathecal, or not intrathecal, of vincristine, and the patient was getting it, and they had a sticker on it, and it got removed, and somebody didn't look at it, and they gave it, and they only they only received maybe 1/10 of the dose before they noticed that they were infusing like vincristine. So the patient did not die. The patient was admitted, but the patient wasn't, they did have paralysis. They were not able to, they did not walk out of the hospital when they were on B66. And that's a tenth of what a standard dose was. So that would be like 0.2 milligrams. So all the cases, they tell you what to do here, which may make sense, but I don't know of anybody reports of people who've gotten a full dose and actually have not died. So now they're in bags, which makes it much more difficult to get intrathecally mixed up. So they are potent vesicants. And I'm just going to mention here that we have really good guidelines on Uconnect for chemotherapy extravasation. This is the one that you can remember that it uses warm compresses instead of ice. Most of the other ones you use ice. You can also use hyaluronidase. Basically causes dispersion and decreased concentration of the drug. Multiple injections. So neurotoxic manifestations are similar with each one, but vinblastine and vinorelbine reactions are less common and severe. The dose-limiting toxicity, neurotoxicity is dose-limiting for vincristine and appears after 5 to 8 milligrams and can be profound after 15 to 20. And this, I had to put this one in because this is Paul Carbone, our cancer center is named at. This is was appeared in blood in 1963. And if we look at the doses here, they basically titrated or treated these patients to toxicity. And they found out there were 40 patients in this study, multiple different types of cancers. And like I said, they titrated to toxicity. They did recover, and they had found out that, like, I believe 10, I think they were Hodgkin's patients, 10 of 10 of the Hodgkin's patients in this 40 patient pool, like, had a total, not a complete response, but had a response to this. And if we look here at the doses here, this is the dose that they found in this paper article that was the maximum tolerated dose. So 0.5 milligrams per kilogram for an 80 kilogram person is going to be 4 milligrams per week, which is a huge dose. People would not think of doing that now. And looking back, it's like, they didn't have a lot of drugs to use, and the fact is that they were getting responses is by they kind of picked that dose. This is pretty much what we would limit now is 2 milligrams per week. So it's peripheral symmetric, mixed sensory motor, numbness and tingling in the extremities is early, loss of deep tendon reflexes is early, motor weakness. This may change depending, this is one of the drugs that usually decreased or dropped first. In combination regimens. So sensory changes do not warrant an immediate reduction in drug dose. I think some people are more conservative if the patient has risk factors. Loss of motor function should result in discontinuation of the drug. And there's really no good pharmacological treatment to reduce this. And again, some risk factors are cumulative dose, pre-existing neurological disease, so alcoholic or diabetic associated neuropathies, poor nutrition, combination with isoniazid or L-asparaginase and etoposide. This is just another slide saying the max dose is 2 milligrams. And I'm going to, how much time is left?
Now we're getting close.
Okay, so I won't go through all of these. This had red on it, so that might be important. Oh, so this is another one that we just talked about that you really do need dose adjustments for this one. And then we won't go to these, that's just for your information. I don't know how I get to, oh. Here. So to answer the question, which you've all been thinking about in your background, is why do we use body surface area? I don't know why that. So this again is an old study. So the reason they use body surface area is basically they looked at, they had the anthropomorphic scaling, so you're going from different animal species. In this case, this is just one example, from mouse to hamster to rat to a man. And they titrated the study animals that they did basically to a toxicity point. So, and then they compared it with like what was, I don't know what they used for man. And the closest that they could find, like if you look at the dose range here per kilogram, or this one actually even more, like if you're looking the dose per kilogram per day, it wasn't even close. But what they found is the closest thing that related to toxicity they were looking at happened to be doses per meter squared, which are all very similar here. So they did this in peds when they were treating, early on, like ALL, and they found out that, oh, if we can extrapolate this to toxicity, we're going to start using meter squared in our clinical trials. So it really didn't even have anything to do with efficacy. I question whether we would actually do that now versus something like lean body weight that might seem to make more sense. So once they started this was popular. You had it published, is they switched over, like I said, with children being treated, leading away and using doses per meter squared. All right. So what questions or comments